In this second presentation, I will focus on the measurements and data, because we've been talking a lot about optimizing, but we can't optimize something blindly. We need data. We need to know what doses we have for both patients and personnel to be able to act upon them and to reduce them. So, and we need, of course, correct data, and that's also a part of the monitoring process. So in this presentation, I will discuss the current and emerging tools for dose monitoring for patients and personnel. And I will start with the patients, and then we'll move in the second part of the presentation on the occupational exposure monitoring. So the IAEA published recently, 2 years ago, a safety report on patient radiation exposure monitoring. It's freely available, in which the patient exposure monitoring is defined as components, mechanisms, and operational processes that are related to recording, collecting, and analyzing patient radiation exposure data associated with clinical imaging operation. That means we need to pay attention at each of these stages on, of course, the measurement part, then recording part, collection, and analysis. And to be able to make a reliable, we need reliable data to be able to analyze them properly. And I'll try to give some examples on these different stages and importance and how we are using this data at the end. So first, maybe we need to ask ourselves why we need to monitor patient exposure, why we need to know patient dose. Of course, the ideal goal is to estimate radiation risk to the exposed individual. Although we don't always need to know individual risk for every patient, because we should not forget that we are using imaging for diagnosis. So that's the primary goal, not exposure itself. Exposure is just a side factor that we need to pay attention to, but we don't need to have a detailed estimation of radiation risk maybe for every individual. Maybe that will be in future, and that's the future developments we are moving into, but we are not yet there because radiation risk itself depends on not just the dose, it depends on many other factors like the age, sex, body habitus, health status. So we need to account for all these factors to be able, based on the dose, to estimate risk. So we have instead, in reality, because individual risk is unknown or unknowable, in reality we have a spectrum of those quantities starting from measurable at the modality level, and here we have different quantities depending on the modality. Is it radiography or fluoroscopy or computed tomography or dental radiography? Unfortunately, because of different geometry, different nature of image formation, we have to use a different measurable quantity for this. So there is a spectrum of modality-specific quantities. And based on them, we can calculate already quantities that are closer to the risk, but they are still not risk, individual risk quantities. Organ doses, equivalent doses to the organs, absorbed and equivalent doses, and combine them in a specific risk index. What is currently available is effective dose, but there are other proposals, and here we expect in near future the International Commission of Radiological Protection to probably introduce and standardize a better patient-specific risk index, because the reality nowadays shows that we need to change the paradigm. We need something better than we have now. But I'm going to talk on what we have now, and of course where we are moving into which direction. Measurable quantities, although they are not patient doses, they are very useful because they can be measured with a good accuracy, 10, 20, 25% accuracy, and they can be used for quality assurance, quality control, for performance assessment, for establishing diagnostic reference levels and benchmarking between facilities, and for local dose audits and optimization of clinical protocols. I'll give you examples in a few minutes. And then calculated quantities, organ doses, effective dose, we can use for example, prevention of skin injuries. For this, we need to know skin dose. Estimation of risk to embryo or fetus if a pregnant patient needs an for example. For comparison of risk from different imaging procedures, if we want to compare what is the relative risk from CT, from interventional, from radiography procedure, or from nuclear medicine procedure, this is the only way of using these estimated risk metrics. And if needed, we may aim to assess individual patient risk using risk factors from published epidemiological studies and risk publications. So let's focus first on measurable quantities, few words about them. In fluoroscopy that we are talking on this today, we have two quantities that are integrated nowadays into the fluoroscopy systems. Kerma area product or dose area product, that is abbreviation CAP or DAP is used. It's in fact the product of the air kerma in a specific plane from normally at the entrance plane, at the entrance surface of the patient, but it could be measured at any other distance from the X-ray source because it's a product of the dose and area. Using the inverse square law, the kerma is reducing inversely to the distance, the square of the distance, and area is increasing. So when we multiply them, in fact, this quantity is almost constant. It does not change, so it's independent on the distance from the focus. That's why we usually measure this at the exit of the X-ray tube with an integrated chamber that is integrated into the X-ray tube. You see here, it's a very old picture. In my first measurements in a angiography system that did not have DAP meter. So with the engineers, we are mounting here such a chamber. You see here, this is the transparent chamber that engineers inserted, and we use this for our first measurements in interventional cardiology. Of course, nowadays, as I said, explained in my first presentation, it's mandated by the IAEA. So all new equipment should have this integrated, either physical chamber like this, or in the new flat panel detector systems, it's computed from the digital signal. It does not need to be a measuring device, but still the same quantities is integrated. The second quantity is the reference air kerma. It's called air kerma at the patient at the reference point. It's also defined depending on the system you have, so you should carefully check the manufacturer documentation. Normally it's 15 centimeters from the isocenter for the C-arm systems in the direction of the to the focal spot, because at that point, if the patient lies on the table and the patient the object is in the isocenter, normally at that point is typically the patient's skin. So reference air kerma, or cumulative dose is also another term, could be, is one of the best available nowadays estimation of the skin dose, although it's not exactly the skin dose. I'll show this in few minutes. So it's a closest approximation for the skin dose. So DAP and reference air kerma should be displayed on all fluoroscopy equipment. Integrated values at the end of the procedure should be exported into the procedure report in the radiation dose structured report. So they are usually displayed in the room. So you see the rates, how they are changing during the procedure, integrated values at the end of the procedure or at the end of the run. And they are also displayed in the control room. This on the right side, this one is the same values shown on the monitors in the control room, and this is already in the report that goes into the archive of the procedure. So they should be verified by medical physicists during the acceptance and quality control, and the acceptable maximum tolerance is plus minus 35%, although we recently performed a study in which we collected information. In some places, 20–25% is required as a tolerance locally. But what IEC recommend, or its maximum 35%, if there is a higher difference, it should be either corrected by the engineers, or if possible, correction factors should be applied afterward. This is from the IAEA safety report, because it's not sufficient to collect only dose indices. If we want to understand how to optimize the procedure, we need more data to be monitored, not just patient dose quantities. And here you see we define 3 levels of data collection depending on the tools we have. If we are collecting them manually, extracting from the archives, we are at the level of level 1. That is minimum we need to know. Total, of course, patient information, patient age and total weight, but also total number of series, total fluoroscopy time, DAP, cumulative reference air kerma, and calibration factors. And then, of course, if you have better access, for example, to automatic dose monitoring systems that I will show in a few minutes, we can, in fact, have access to everything, all the information, technical factors, procedure-related factors, and image quality metrics at the higher level. And this will give us a powerful tool for optimization. So, how we are using this? The first example I want to give is to establish so-called diagnostic reference levels, because they are diagnostic because they were introduced for diagnostic radiology first, but they are applicable to interventional radiology, and that is already mandated by the ISRP. There are some debates to replace diagnostic with dose reference levels, but doesn't matter, the term is there, the concept is the same. What is the concept? We collect sample of patient doses and we are comparing typical practice in different facilities in a country or a part of a country by collecting specific procedures and patients of similar size. For example, 50 patients for EVAR procedure performed in 20 different departments in the country. We need to have standardized naming of the procedure. That's the first step. We need to define what typical patient means. Of course, we don't collect data for only 70 kilos patient, for example. We collect a sample of patient in the range 50 to 90 kilos or different, aiming to have the average weight the same on different facilities, different departments, and for the same type of procedure. In this case, we can compare these between departments. And what we do for a specific X-ray room and geography system, we perform statistical analysis and calculate the median of the distribution of patient dose indices, DAP or reference erg-KERMA, and this we call typical dose, the median, because median is less sensitive to outliers than the average. That's why we don't use median, average, mean, we use median. Then we collect all medians from different departments, put them together, pull them, and calculate again, descriptive statistic, and at the third quartile, at the 75th percentile of the distribution of medians, we set our diagnostic reference level or dose reference level. Why? Because it's a pragmatic approach. It's not huge mathematics, but in this case, we'll have 25% of the rooms of the facilities that exceed DRL. And these 25% are our primary focus for optimization. We should investigate, because after we set DRLs, then comparison with DRLs of the local typical doses comes and optimization opportunities. So these are the requirements. It's required by the European directive, so it's a legal requirement that every country should establish and regularly review and use diagnostic reference levels. And you see here that interventional radiology is also included in the requirement. And then member states shall ensure that in every department appropriate local reviews are undertaken to compare to DRLs and take appropriate corrective actions. I decided to give an example from my local practice, although there are many published, of course, in the literature. These are examples from the first national survey in Bulgaria that I coordinated in 2008-9, but we finished in 10-11. And we are able to set DRLs for only 3 procedures: cardiac angiography, PCI, percutaneous intervention, and lower limb angiography from non-cardiac, but the third is not shown here. So you see here, 10, I think, equipment were surveyed at that time, and these red columns that are median doses for the same procedure, CA on the left and PCA on the right, for the same procedure in the same standard typical patient with average weight of around 70 kilo. Red bars are DAP, dose area product. Blue bars are fluoroscopy time. And you see that for the same procedure, median doses vary quite significantly, 5-fold for CAP, 3-fold for fluoroscopy time, and similar variations for PCI. So this is because of different practice, although there is another factor that influence, and we set DRLs at that time for CA it was 40 gray centimeter square, for PCI it was 140. Then there was another second survey 7 years later, and the current DRLs are based, and now my colleagues are planning a third survey. We should very carefully consider, together with clinical professionals, how to classify procedure, because there are many papers published showing that in interventional radiology and cardiology, the complexity of procedure has very important influence on the dose, and I think it's clear. So these are one of the 2 papers from the first attempt to set DRLs for cardiac procedures. On the left side, this is from 2000. On the right side this is the IAEA research project in 2008, in which procedures were classified as simple, medium, and complex. And you can go into the papers to see the criteria. It's the number of stents. It depends on the type of the procedure. And you see that there is a difference in the dose area product depending on the complexity of the, and these are again based on samples, based on medians, so it's somehow averaging individual variations between individual doses. So complex procedures usually require 2 times higher dose compared to the simple, and that's natural. So this is from the National Survey in Spain, published in 2016 for 7 procedures, in which they used also the same approach with simple, medium, and complex. And you see the criteria they used for each of these procedures. I think this is one of the most comprehensive papers published on dose monitoring based on complexity. And they set DRLs for these 3 categories of complexity. This is a very recent paper published by my colleague in Bulgaria, she's medical physicist, but she works in close cooperation with vascular surgeons to set, this is another, it's on electrophysiology studies. They also used 3 classification descriptions: diagnostic procedures, simple ablations, and complex ablations, and said, because there were only 3 hospitals included here, of course, DRL cannot be exactly set based on only 3 hospitals, but in fact, they proposed some standardization of this dose monitoring approach. So you can find DRLs published. I just decided to include some examples from the UK. UK has longest traditions. In fact, the term diagnostic reference level concept was introduced in the UK. These are the current. You can find them on the website. These are from an European study from 13 countries for interventional cardiology. Another study on interventional radiology, Wykład study, in which European Society of Radiology worked together with the European Federation of Medical Physics and Radiographer Society, again from 13 countries, and they were able to collect sufficient data to set DRLs, European DRLs, for 4 clinical indications in interventional radiology. It's important when we plan a study, especially nationwide, to properly plan data collection, because in the past we used paper forms that were distributed, then we moved to digital spreadsheets, Excel spreadsheets, but it's a very difficult and heavy process that you need someone to record doses, to extract them from the archive. That's why the modern approach is automatic dose monitoring, and it's available nowadays. There is standardization with the initiative of the vendors called Integrating the Healthcare Enterprise with so-called REM, Radiation Exposure Monitoring Profile, that standardize and make this possible to collect data from various vendors in a vendor-independent manner. So that's why the modern commercial software, there are maybe more than 10, 15 commercial vendors providing software for data collection, automatic data collection. The key here is automatic. It retrieves data automatically from the machine without human interaction. Of course, human is behind because we need to check the correctness of this at every step. It also provides some analytical dashboards with a lot of analytical uses for this. They are also open source software. They need, of course, qualified users, IT specialists and medical physicists to install them and test them. So they are developments, and this is the future. This is the really very fast development of the field. And this could be used at the hospital level, but it could be used at the local sub-hospital, set of hospitals, or even national level. The first fully automatic national dose registry was installed, but was developed in the United States, initiative of the American College of Radiology, so-called DIR registry. First for CT. It collects the individual CT machines are connected to the registry, and this provides periodic analytical feedback. You can see where your hospital is compared to your peers, to other hospitals, of course, without seeing other individual data. And in 2018, they introduced a module for interventional radiology, and based on the analysis in 23, they published the first national diagnostic reference levels on interventional radiology procedures. We had a webinar with them. You can find on the IAEA website the webinar on interventional data. There are other initiatives. One of the first, the pioneers in Europe, is San Carlos Hospital. That's why we are referring to them quite often in our presentations today. The group of Professor Eliseu Vaniu. Quite many years ago, they developed DOLIR software that was then provided to other hospitals. And here you see 6 university hospitals with 16 catheterization labs are connected to this software. And it provides a very detailed report based on even individual events. During a procedure, you can see different components, fluoroscopy acquisition, and analyze them. So, and this could be used beyond just establishing DRLs. You can see live CAP, live referential KERMA and cumulation, and it also provides immediate feedback if the dose exceeds the trigger and there is a risk for skin injuries for that patient. So using this data, because you need data to be able to optimize, so you need to then look at all the factors that contribute and apply changes and optimize practice. So here are just one example how staff experience influence patient doses. So they compared different radial approach and left radial and right radial approach performed by senior physicians and fellow physicians, and there is a difference how experience influence those. And the last in this is there is a novel approach. This is also a very recent paper from John Domilakis' group in Creta in Greece on using AI for helping us extract data and analyze this. The example they provided in this paper is on EVER as a case example. And this demonstrates that in future maybe AI will help not only collect properly data in the registries, but also analyze them in a fast and appropriate model. So if we have measurable quantities, then we can play with them. We can use them to calculate, for example, skin dose. That's of very high importance for interventional radiology. Peak skin dose can, because reference RKRMA is a better indicator for skin injury compared to DAP, for example, and this slide demonstrates that because during the procedure, you can change the projection, you can change the entry point, and in this case, the DAP could be the same, but it could be differently distributed to different areas of the skin. So that's why having real skin dose is important. And in the past, we used either TLD matrix or X-ray films to perform measurements. We put under the patient body or GAF chromic films. But it's very difficult to perform for every patient. We usually did this for complex, when we predict that procedure will be complex, and accuracy depends very much on how you calibrate this device. The modern approach that is available now more and more in dose management systems, but also in real time, it's calculated skin dose. It takes almost all procedures, all approaches use this calculation approach, although there is a very recent paper from a few weeks ago showing another approach. And what this algorithm uses is the DICOM structured report with all the information about the individual radiation events. And in fact, using this information for the procedure, the technical factors, for the orientation of the beam, it could be either calculated by medical physicists, but of course it's much better if it's calculated by a software, dedicated software. So most of the modern dose monitoring systems has such a module that provides post-procedure calculation of skin dose, and you can see if there is a risk of skin injury and act upon this, informing the patient or for being careful for potential developments of any skin reaction. And two vendors already provide real-time display, so it's almost real-time. In the room, there is a display showing the skin map with colors, and the interventionalist or someone else from the staff can monitor this and inform the. But there are also publications showing that there are still variations between these approaches, and we need better harmonization. We can act on this, having information with notification. I had this in my last year presentation, and this is based on the guidelines published quite a long time ago, and they are still unchanged. Also, we need to, after the procedure, to archive this. I'm going faster because I want to go to the occupational as well. And inform the patient to be careful and to watch for any redness or epilation within a month, at least after the procedure, if the peak skin dose exceeded 3 grays or reference air kerma exceeded 5 grays. This is not a threshold. This does not mean that exceeding these levels will definitely have, the patient will have injury, but the risk for injury is increasing if these doses are exceeded, these dose levels are exceeded. So if needed, for example, for pregnant patient, for example, we can calculate fetal dose, or we can calculate all organ doses, and this is done with simulation only calculation. And there are also development in this area with moving from, in the past, geometric phantoms to tomographic phantoms based on real patient images. Patient-specific, we can have a library of phantoms and choose the appropriate for the individual patient that was examined. And the latest developments are on using AI, also machine learning approaches, for because the most difficult here is fast organ segmentation, to be able to then make a Monte Carlo calculation and calculate organ doses. So I used to ask the researchers working on this, are we close to the point when we can have almost real-time organ dosimetry? And we are almost there. In fact, it's possible, and it might be possible in near future. So there are different software products that usually medical physicists are using after the procedure to, if needed, to calculate effective equivalent doses to the organs and combine them into effective dose. But we should be careful. This is not patient dose. This is a reference person dose. So uncertainties here can be above 100%, but it's still very useful. We need in future maybe to standardize also these approaches. They are work on this nowadays. But we can use them to compare typical doses. For example, this is just one example how we can compare different type of procedures. These are typical ranges between 4 categories of procedures, just to be informed which are the highest dose procedures compared to others and to compare to other medical procedures. Okay, I almost used my time, but maybe in 5 minutes, 10 minutes, I can go quickly to the dose monitoring for personnel. It also, we know the dose limits, 20 for the whole body, 20 for the length of the eye, and 500 for the skin and hands and feet. I suppose the same are in Poland. We know that, and Gabriel showed that in reality, if we use all the protection, we may keep them much lower. The real doses are much lower than 20 millisieverts. But of course, they are interventionalists who can reach easily, especially the 20 millisievert for the eye lens, if no protection is used. When we use the term assessment of occupational exposure, it does not always mean measurements, because real measurements, individual monitoring, is needed for those who enter the control area and who are at risk to have relatively high doses. For some of the staff, it might be sufficient to estimate the doses, reconstruct the doses from the workplace monitoring, and I will show some example, but it depends how the national regulation requires. We usually start with the national regulation and with a risk assessment. So who needs dosimetry, who needs monitor, who needs individual dosimeter will depend on the risk assessment. Who enters the control area, who does not enter, what role these people have, what procedures they perform, where they stand during the procedure, are they using personal protective equipment, what is the workload, which are the groups with different workload. And based on this, we usually decide who needs whole body dosimetry. Also, the same approach, and of course we take the worst case scenario, the same approach we use for the estimation who needs eye lens dosimetry, eye lens monitoring, and also finger dosimetry that might be not needed on a regular basis. So these are some recommendations, but they are not requirements. These are recommendations if the monthly dose, for example, we may perform measurements during a 3 months period, and if the monthly dose exceeds 1 millisievert or an annual dose may exceed 10 millisievert, this person, this category of professionals might need regular eye lens monitoring. For the finger dose, although the dose limit is much higher, in fact, most operators maybe will not need regular finger dosimetry. So, but they maybe need such a dosimetry for a certain period to estimate, to assess the doses, and to optimize their practices. And usually, eye lens dosimetry and finger dosimetry is needed for only the main operator who is very close to the beam. So monitoring period also depends on the national regulation. We can discuss this in the discussion part, but usually 1 month for interventionalists, I don't know the Polish requirements, or in 3 months for personnel exposed to lower doses. And it's important that the dosimeters are really used and return on time. And of course, dose report is received in a timely manner, and it's communicated to the professionals to know what are their doses. Calibration is important. Of course, this is in the responsibility of the laboratory performing personal dosimetry. It's a good practice, and it might be required that such a laboratory is approved by the regulatory authority, because we need a guarantee that all dosimeters are properly calibrated. If it's for the whole body, the quantity is personal dose equivalent at 10 millimeters. If it's for the skin or eye lens, it's a different quantity, so it's important. The dosimeters themselves, devices, can be different. They could be passive and active. In the passive dosimetry, in the past, we used film badges. I think majority used thermoluminescent TLDs, but also optically stimulated OSL or radio photoluminescent dosimeters, RPL, are also used. And there is a vendor providing this kind of direct ion storage dosimeters that are also passive, but they are connected wirelessly to the computer. And so these passive dosimeters are usually legal dosimeters. They are the main dosimeters for documentation and regulatory compliance purposes, and which type is used depends on what is approved by the regulatory body. Active dosimeters, electronic dosimeters, have direct reading. They are very useful, but they are usually additional dosimeters because they give an instant indication of the current dose. And it's very important when we are choosing such a dosimeter, especially for interventional radiology. Not all electronic dosimeters are appropriate because many of them are not they have not a proper energy response and not a proper response to pulse fluoroscopy fields that we have in interventional. So they should be carefully selected. The main dosimeter is always there, the whole body dosimeter. But it's recommended for interventional radiology to have a second, to have double dosimetry, 2 dosimeters, one between the shoulder and the waist under the apron, and the second on collar level outside the apron, that is used to estimate the whole body dose, because when you use protection, usually under the apron dosimeter is not sufficient because we have also some of parts of the body that are not protected. So, and also, of course, to estimate the dose to the eye and to the fingers, we need special dedicated dosimeters. We understand that these are not very practical because normally legal dosimeter should be there. And if a person works in 2 facilities, for example, it happens, it should be provided, the legal dosimeter should be provided independently by every employer. I think that this understanding is very important. And also some investigation levels, I'm going quickly because this is usually something that is required by the national legislation. These are not limits. These numbers are much lower than the limits. They are used to inform the radiation protection officer, for example, that the dose to this person, to this individual, exceeded such a level and this might need investigation. What are the working conditions? What can be modified in the working condition to review procedures and performance and take corrective actions before the dose is reaching the dose limit, just to reduce the risk. Real-time dosimetry, Dr. Bartel mentioned about this. These are additional electronic dosimeters that are very good for educational purposes because these are provided by one vendor. You have a display of the dosimeters in the room, just above the image display, and you have the immediate instant feedback on how your dose is accumulated during the procedure. And the recording of this goes to the computer, and every single event is explained. In the IAEA video tutorials, you have one video that shows the practical use. I'll quickly play this. You see here, each of the staff members have such a dosimeter. You see the badge on the apron, and the red bar on the left screen, it's a dosimeter that is positioned on the C-arm. So it's like a control dosimeter. That's why it's much higher. So you see 3 staff members moving in the room, and their doses are changing, going behind, so going on the other side of the room, and immediately the dose increases because that's unprotected side of the room. So another dosimeter might be needed if a pregnant worker continues entering control area. They are young interventionalists who don't want to stop working during the pregnancy. And in this case, of course, it's possible, it's legal to continue working, but they should be provided the same level of protection. I mean, the embryo should be provided the same level of protection as the general public. That means 1 millisievert should not be exceeded during the whole pregnancy. And an additional dosimeter placed on the waist level under the apron may be very useful in this case to provide. So if the dosimeters are not used or they were lost, for example, it could be possible to use this reference electronic dosimeter that is put on the C-arm. And this is an example from San Carlos Hospital again. And here, I borrowed this slide from Professor Vanyo. You see that it's possible to reconstruct the dose if the dosimeter was lost, for example. Having recorded patient dose, DAP, having recorded the C-arm scatter dose by the electronic dosimeter, and then applying corrections for the use of protection devices, you can reconstruct the dose and use this as an additional approach, alternative approach to measurement. It's not yet to replace. The same group developed an additional approach with mobile phones, smartphones used, I mean, the same real-time dosimeters, sending report directly to the individual mobile phones of the staff, creating their cumulative dose reports. And on the right side, you see how their individual dose accumulates during the procedures compared to other staff in the department. And the last is I think this is the future, the computational real-time dosimetry. The approach was developed under the European PODIUM project, personal online dosimetry. So they used flexible mesh individualized phantoms, camera tracking staff movement, camera inside, video camera in the room, and data from the radiation dose structured report, providing data for the source. Combining this using the depth camera image, reconstructing the different poses of the operators, and then applying Monte Carlo calculations for real-time dose calculations. So this was published in a number of papers. I refer you to these papers. And the paper of Philip Van Hevere on advances in personal dosimetry also opened the future of development of this, and the latest they proposed, they are still not published papers on the application and verification, using machine learning methods combined with this motion tracking to replace the real Monte Carlo simulations, predicting from the data, of course, because we need data from procedures. And this is my last slide. In future, and this is already reality in some places, again from San Carlos Hospital, when we have simultaneous registration of both patient and personnel doses combined in the same registry, because in this case we can integrate the information and use this for optimization using both patient doses and staff doses from real-time electronic dosimetry and applying modification of the practice based on data, because data are crucial when we want to change the practice. So, and this is my message. Dose monitoring for patients and personnel are equally important, and novel active and computational dosimetry approaches, automatic monitoring and integration provide opportunities for dose reduction and procedure optimization. Thank you, and I'm sorry for exceeding the time.